I'm Dr. Richa Thakur. I'm a second-year oncology fellow at Northwell, and I'm here with one of my colleagues also on the Onc Data Forum, Dr. Haque. And we really have a great video planned for you guys today.
Hey, thanks so much for the introduction, Richa. I'm Waqas. I'm a third-year medicine resident at NYU in a clinical investigator track, and looking forward to having a really important discussion with you about, National Awareness Immunization Month.
So if you guys don't know, August is the National Awareness for Immunization Month, and we thought it'd be really great to talk about a few different topics on vaccines and what would be important to our cancer patients too. Hopefully you guys like this, and we really do want to increase awareness to get vaccinated. Whatever the vaccine series is, please share this video so that they're also motivated to go get their vaccines.
And Dr. Thakur, why don't you tell us a little bit about sort of the importance of the month for you and sort of how it's significant in your practice?
So of course,
Yeah.
I mean, growing up, I always wanted to be a physician. And one of the stories that would always capture me was listening to my grandparents and parents talk about what the world was like before polio and watching like the smallpox vaccine eradicate. And I was just always mesmerized by these. In 2020, especially as a resident in New York, I saw how terrible COVID could be. And that was the world without just one vaccine. And after like December, when it first came out, it completely changed the landscape for treatment for our patients. And so that's really what has made me so passionate about vaccines. And especially with our cancer patients, these vaccines are huge. They may not do as much for someone that's 20 and gets the flu, for example. Younger, healthier patients are less likely to end up in a hospital. But for our cancer patients, that's huge. A patient in the hospital having delays in treatment, that can take someone from a curative intent treatment, cause significant delays in their treatment and not only their overall quality of life, but their chances of responding to the treatment. So, Dr. Haque, why are you so passionate about immunizations?
Yeah, it's really interesting that you mentioned that you were sort of in New York during the height of the pandemic. I think I started residency a year after you, so I was kind of a little bit after the class of residents that were kind of the COVID interns. But I was actually at Baltimore doing my master's in public health at the time at Johns Hopkins, and I was taking all these classes on immunizations and epidemiology and health management, and then to just kind of see the pandemic start, actually in the middle of my MPH, I just kind of put all the classes and all the theory I was learning into practice, and that really cemented, I think, the importance of vaccinations for me. And even though I haven't started my fellowship yet, I have rotated in several inpatient and outpatient oncology clinics, and it's really surprising to see, like a lot of times when I ask patients about their immunizations, especially for like immunosuppressed patients, how often many of them may not have the flu vaccine up to date or aren't, vaccinated against invasive pneumococcal disease. So I think this month is really important for both providers and patients to kind of reflect on the role of immunizations, and hopefully we can kind of have a good discussion about this today. So the first thing I kind of wanted to ask you about is there are sort of a handful of vaccines that we know can help prevent cancer, of course for hepatitis and also for HPV. So I kind of want to first talk about the importance of the Gardasil vaccine, the HPV vaccine. There's obviously a lot of stigma around it, and we both come from South Asian background, and there can be different kind of perceptions on it in different communities. So I was kind of hoping you could talk a little bit about your experience of the vaccine.
Absolutely. I think that's a really good point. Usually, a lot of times when I was in medical school and we talked about vaccine hesitancy, the focus of the conversations I felt like were always around minority populations, people that were stigmatized by the general literature in like publications, but also patients with like low socioeconomic backgrounds and low health literacy. One thing that really bothers me a lot about the hesitancy with Gardasil is there's so much stigma, especially in well-educated communities. And it's really around the association with HPV being a sexually transmitted infection. And the thing is, there's not that many vaccines and things that can prevent cancer. There's really two big ones, hepatitis B and like any one of the HPV series. So it breaks my heart seeing patients, especially in like our clinic, that are suffering from head and neck cancers or anal cancers or cervical cancers that are so preventable. And it's 3 shots and they wouldn't have had to go through a lifetime sequela of treatment and the complications from their treatment had they just gotten the vaccine. And unfortunately, for some of the patients I have, they weren't lucky enough to have this before they were exposed to HPV. But nowadays we have this vaccine and it's just so miraculous. More people should go out and get it. In terms of the vaccines, there's three really big buckets. I think we were probably in middle school. The original vaccine came out, which was the Gardasil, and that was the quadrivalent that protected against HPV 16 and 18. And then there's also like Cervarix, which is 3 shots. But now there's another series too called Gardasil 9 that has 9 different series of strains of HPV. So being able to get this is huge because 70% of head and neck cancers, or upwards of 80% of cervical cancers are associated with HPV. And being able to get this really prevents a lot of unnecessary treatments that these patients would have to get had they developed cancer. The other thing we should also probably talk about is when this vaccine first came out, really the inclusion criteria was pretty limited. It was mostly like teenage women, I think, and then they started adding men. And probably for most of our training, even in medical school, the literature recommended the HPV vaccine, any one of the series, for patients that were 9 to 26. And even the 21 was expanded to 26 probably when I was in college or medical school. But I think one thing people don't realize now is that there's also an increased expansion for people from 26 to 45. So CDC recommends it for everyone under 26, but between 27 and 45, they do recommend it for patients and recommend it as like a risk-benefit discussion with your physician. So I feel like the stigma with HPV is pretty huge, but I'm sure Dr. Haque, you also experience a lot of stigma in the clinics too, right? With not just Gardasil, but a lot of other vaccines too.
Yeah.
What's your experience been like?
Yeah, definitely. So I think one of the cool things about being at NYU is that I'm in a 3 hospital system. So you have a private hospital that I'm working at, and then you have the Bellevue, which is sort of one of the country's oldest public hospitals, and I'm also at the VA. So really 3 different patient populations, and I've seen vaccine hesitancy sort of wrapped up in different buckets in all 3 hospitals and different patient populations. I've definitely seen my fair share of patients, even ones who are immunosuppressed, who might be hesitant about keeping up with vaccines, or who might have some doubts about the efficacy of them, especially if they've, still had cancer, or if they still had some kind of complication or infection even after getting immunized. I think the first thing that's been really helpful for me is just really using plain language when I talk about vaccine safety. And I'm sure, like a lot of other trainees and physicians know about this, but really just using the share approach so that when you speak about vaccines, it's not like you're talking down to a patient, but you're kind of trying to make a decision with them. So you kind of get a sense of what their values are, what their preferences are, and also getting a sense of where they're coming from. Do they have any family members or cousins or siblings or parents who did or didn't have a vaccine? Do they have any traumatic experiences with them, or is there any mistrust with the medical community or medical system? So getting a sense where they're coming from and just trying to empathize with them, and then kind of informing them sort of the pros and cons of vaccination after that, and usually trying to reach a decision with them. And personally, I've found a lot of benefit with this approach, and it makes things a lot less tense, especially when there is a patient who's pre-contemplative or contemplative about a vaccine. So that's sort of been my experience in the outpatient clinic, in the outpatient clinic setting.
So the share approach isn't something I think I really was taught in
Mhm.
residency or medical school as much. I'm familiar with it a little bit, but would you mind going over it a little bit more? Because I think that would really
Yes.
help a lot of physicians have another tool to talk about
Yeah.
vaccine hesitancy.
Yeah, for sure. So the share approach was developed by the AHRQ, and it's one of the it's basically a 5-step approach to approach decision making with the patient. So step one is where you're seeking your patient's participation. So you're really just trying to bring up the topic with them and just get a sense of where they're coming from when it comes to discussing the vaccine. H is helping your patient explore and compare treatment options. So you're kind of talking to your patient about getting vaccinated now versus vaccinated later, versus not getting vaccinated at all. And just once again, just trying to get a sense of where they're at in terms of knowing the pros and cons of each of those options. Then you go on to A, which is where you assess your patient's values and preferences. So this is where you have I think, the best shot to empathize with your patient. You kind of ask if they've had any family members who have gotten the vaccine, if they've had any bad experiences with vaccines, what they know about vaccines from the TV or media, right? R is where you reach a decision with your patient, right? So you've gone over the pros and cons of the different options, and now you're kind of making a choice with them. And then E is where you evaluate the patient's decision. So obviously, we're not always going to get the answer we want, but hopefully they decide that they want to get vaccinated, and you say that this is a great choice. You're going to hopefully, potentially add years to your life, by preventing, something down the road. So that's sort of the approach that I've used as a resident, and it's been very helpful.
I really like that framework. I'm definitely going to take that away and try to use it more often, especially not just with vaccines, but with other like treatments that I
Yeah.
think patients are very hesitant to pursue.
Oh yeah, it's yeah, definitely very helpful, not just for immunizations, but for other things as well. And just to kind of build on that, I know that you're obviously in the middle of a fellowship, and you're having to probably help administer chemotherapy or different cancer treatments. So I'm kind of curious how you talk to patients about immunization scheduling around chemotherapies, and sort of your experience with that.
Right. So, fortunately for us, a lot of our patients do have really good primary care doctors that are on top of most of the vaccine series. So, as an oncology fellow, I focus more on ones that are affected with their treatment or the annual ones that they really do need to make sure they get. So, flu, COVID vaccines are usually the ones I bring up the most often with patients. I think there's also, depending on the treatments, there are some special considerations with a few. So, for example, when patients have some sort of treatment like a CD20 inhibitor, like rituximab, they may not always have a good response to the vaccine. So, counseling patients on getting them before you start treatment, or if the vaccine can be delayed until several months after they finish treatment to time it so that they would have a better response. The other approach sometimes is there are some treatments like eculizumab, which affects certain pathways in the immune system, so like the complement mediated pathway, and making sure these patients have like the meningococcal vaccine that's timed relative to the dose of the treatment is also really important. But I think one of the biggest patient populations that a lot of patients or primary care physicians don't know about too is our transplant patients. So for patients that have some sort of blood cancer, so usually leukemia or myeloma, that are often undergoing curative intent treatment, or not in myeloma, but at least in leukemias, these patients have to get an entire bone marrow stem cell transplant. So they undergo high intensive chemotherapy, and then they're given their stem cells back, or like a donor stem
Mhm.
cell back. But because of that high intensive chemotherapy, they literally have wiped out every immune cell they have in their body. So for the first year, you really can't vaccinate a lot of these patients. And depending on complications from the transplant, we would start flu and the COVID vaccine maybe 6 months out, but that's also assuming they don't have complications from the transplant itself.
Mhm.
And even some of the other vaccines, you have to delay significantly. So, transplant patients have to get the entire primary series. So, all of the
Mhm.
vaccines you and I got as a kid, again after
Yeah.
transplant. And even some of the live attenuated ones like varicella or MMR, they're not able to get until 2 years
Right.
after transplant minimum. Because these patients are such high risk, it's really hard for our transplant patients and a lot of our cancer patients to be protected from these infections.
Right.
So we really do rely on a lot of healthy people getting these vaccines to help protect the crowd.
Yeah, definitely. And I think one of the interesting things is that when you think about understanding the efficacy of vaccines, or understanding the disease prevention, a lot of the trials that are done to understand these vaccines aren't really going to include cancer patients in the first place. So that's why there's sort of a lack of sort of hard data. If the patient ever asks you about sort of what's my chance of not getting a complication if I do have cancer with the vaccines. But interestingly, there have been some studies that have tried to at least explore this association, and I do know that the inactivated varicella zoster vaccine has been shown to reduce, zoster severity in adults who have stem cell transplant. And also the inactivated influenza vaccine has been shown to reduce severity in cancer patients who get the flu. So there is some evidence, but unfortunately, like trials just not powered to kind of explore this relationship. But definitely very important that we have these guidelines that you're talking about.
So, what other resources have you found that you think would help other physicians or trainees or even patients with like getting vaccines or keeping an eye on what they need?
Yeah, so the first thing for me that's really helpful is the CDC does have guidelines on vaccinations and the IDSA as well. They have guidelines that have been updated as early as this month actually, and they have a special section for patients with altered immune incompetence. So that's really the best way for me to keep up with these things because every year there are going to be some changes here and there in patients, and also the National Immunization Awareness Month website has really good resources for both care providers and for patients' family members. So for patients, they have some apps where you can kind of check if you need to get a vaccine or not and help you keep up with that, and just some general counseling. And providers as well that has some links to the different schedules that you should be following for patients. So that's a really nice website that I really like.
Dr. Hawk, I really love the resources that you gave. And I also found another one online on the CDC website too, which we can definitely put out in the show notes of this podcast. But it has a couple of quizzes for children and adults, very simple questions, and it'll tell you what vaccines you need and if you're missing
Yeah.
any. For anyone that's listening, if you know anyone that's not vaccinated, please send them this video. Encourage them to go out and get vaccinated because it's so important to keep our community healthy.
No, thanks so much. To go for sharing that resource and not just for patients to get vaccines, but also if you're a family member or if you have a loved one who has cancer, then definitely stay with the vaccines as well. We know that vaccinated close contacts and family members of patients can create a cocooning effect where hopefully you're able to kind of block out the effect of that disease or virus in the patient's household. So definitely it should be for everybody, not just for cancer patients.